Hi, everybody. Thank you ever so much once again for tuning in on a Tuesday evening. We again have Dr. Fredrika, who is going to be going through some of the more common obstetric conditions that you will find yourself facing when you get thrown onto the wards.
Yeah, excellent. Okay, hello everyone, and it's great to be back. And also, just for those of you who are new, my name is Fredrika. I'm a foundation doctor at Northwick Park, but I'm giving these tutorials partly because I did a PhD in fetal growth restriction before, so that's how I got involved in this teaching. Last week we talked about emergencies. This week we're going to talk about common obstetric conditions. The key things we're going to focus on is really hypertension and diabetes in pregnancy, but there's a lot of other things going on, and let's get cracking. Okay, so objectives of this session are that by the end of this tutorial, you should be familiar with various hypertensive conditions of pregnancy, ranging from pre-existing hypertension all the way through to preeclampsia. We're going to look at gestational diabetes, both in terms of risk factors and management, complications. We're going to have a look at common and/or serious infections in pregnancy, discuss obstetric cholestasis in brief, and then at the end we're going to go through common and important psychiatric conditions of pregnancy. Okay, so starting with hypertension in pregnancy. As many of you already know, in a normal pregnancy, blood pressure usually falls in the first trimester, particularly the diastolic blood pressure falls, and then it continues to fall until about 20 weeks. So I'd say 20 rather than 24 weeks there. After that time, the blood pressure usually increases to pre-pregnancy levels or slightly above pre-pregnancy levels by term. I'd like you to ignore the red bar there because those are unadjusted values. So those values haven't adjusted for things like multiparity and ethnicity and various things that are important. I'd like you to focus only on the blue lines. This is from a huge study in the BMJ, which is more than 15 years old now. I think it looked at over 150,000 women, and it measured blood pressure throughout pregnancy. And what you can see is up until mid-pregnancy, just above 20 weeks, you see the diastolic blood pressure falling. And then especially in the third trimester, you see it slowly rising again. Overall, there's about a 2 millimeters of mercury increase in diastolic blood pressure from booking levels to end of pregnancy, which is quite common. But I want you to remember that curve where it slowly goes down and then rises towards the end of pregnancy. Okay, and that's a really nice study. If you want to have a look at that later, I've put in a link to that at the end as well. Okay, and do feel free to ask any questions. Yeah? Okay, so what's the definition of hypertension in pregnancy? Well, it's very much the same as hypertension outside of pregnancy, meaning a systolic blood pressure of over 140 or a diastolic pressure of above 90 is the definition of hypertension. Okay. Also, if your systolic blood pressure rises by more than 30 or your diastolic by more than 15, that would also classify as hypertension in pregnancy. And we're going to go through the key causes, which are both ranging from pre-existing hypertension, pregnancy-induced hypertension or gestational hypertension, and preeclampsia to eclampsia. We discussed preeclampsia and eclampsia a lot last week, so I'm not going to go into that too much. But that little diagram that I've popped there on the left really summarizes everything really well. So maybe just have a look at that when we share some of the slides afterwards, okay? So the first disorder of high blood pressure in pregnancy is pre-existing hypertension. So these are women who rock up usually to the booking appointment, which is very early in pregnancy. It can be from 6-7 weeks even up until say 13-14 weeks. And you find that they have a high blood pressure already early in pregnancy, before 20 weeks. They can have a history of symptoms of things like frontal headaches and anything like retinopathy or family history of hypertension is quite common, etc., etc. And these women tend to have either no proteinuria or just a tiny little plus of proteinuria on your dipstick. They're not edematous, and as with all causes of high blood pressure, it's more common in older women. I mean, just looking at that graph there, you can see that systolic blood pressure basically rises in a linear fashion from 40 years onwards. So it's not surprising that this is more common in older women. And then I know this is quite an overwhelming slide. I'm going to go through it just very briefly. Pregnancy-induced hypertension or gestational hypertension is defined as a blood pressure which is above 140/90 occurring in the second half of pregnancy. So these are women who've had a normal blood pressure up to 20 weeks and then develop high blood pressure. Again, no proteinuria, no edema. It affects about 1 in 20 women, and it resolves following birth. But what I think is really important, both when we discuss gestational hypertension and gestational diabetes, is to recognize that even if these conditions resolve after pregnancy, it puts those women, or it's associated in those women with an increased risk of developing hypertension and diabetes respectively later in life. So my one of the professors I worked with, he always discussed diabetes in pregnancy and hypertension in pregnancy as kind of unmasking processes that were going on already before the pregnancy. And the pregnancy is like a stress test for the body. So if someone is prone to or predisposed to developing hypertension or diabetes, this stress test of pregnancy tends to unmask it. So risk factors for gestational hypertension are exactly those which are true for hypertension outside pregnancy: family history, diet and lifestyle disorders, or rather poor diet and lifestyle, and various genetic conditions, of course. So I put those slides there, or the picture there on the left on the slide, just to show that a lot of the gestational hypertension that we see could potentially be modified by lifestyle factors. Things like reduced salt intake, things like a good diet and exercise. And that is effectively what all of those graphs show, is that women who are obese, women who have a low level of physical activity, women who have a high salt intake and a poor diet are much more likely to develop hypertension later in life after having had gestational hypertension. Yeah. So I've got a question here. If someone has a high blood pressure after 20 weeks, how would you know if that they didn't have pre-existing hypertension? Well, the key thing is here that they should present, or they have their booking appointment early in pregnancy, and you measure blood pressure every single time a pregnant woman comes in. So obviously, if you as a clinician or midwife or GP or anything like that have not seen a woman up until 20 weeks of pregnancy, then you won't be able to diagnose whether or not this was pre-existing or gestational. But by 20 weeks, most women will have had at least 2, probably 3 visits to their midwife or practitioner, general practitioner, where their blood pressure would have been measured. So if at any of those points blood pressure was normal, then and then you develop hypertension after 20 weeks, then it's a case of gestational hypertension. So it's really just about comparing either pre-pregnancy blood pressure or booking blood pressure. So booking is that first appointment with your midwife in early pregnancy, and comparing that to a blood pressure reading in later pregnancy. That's how you determine. So you basically need a baseline. I hope that makes sense, but it's a really good question, so keep them coming and let me know if it's unclear. Okay, well done. So yeah, lifestyle is important in these cases, yeah. And then preeclampsia, this we discussed quite at length last time, so I want to just go over it relatively quickly today. Again, it involves hypertension defined just as before, systolic above 140, diastolic above 90. It's seen after 20 weeks of gestation. The key thing here is that it's associated with proteinuria, quite high levels of protein in the blood, right? It affects about 1 in 20 pregnancies. A lot more research is needed in how we can prevent this condition and also treat it once it happens, partly because it is associated with quite a lot of adverse outcomes for both mom and baby. Yeah. So for the baby, prematurity and fetal growth restriction are key associations, and for the mother, eclampsia, so seizures associated with preeclampsia, cardiac failure, and even multi-organ failure can be consequences of poorly treated preeclampsia. So I really want you to think of those disorders as a spectrum: gestational hypertension, preeclampsia, and eclampsia. Excellent. Okay, let's move on. The risk factors for preeclampsia were discussed at length last week as well. They tend to be divided into high risk factors and moderate risk factors. The high risk factors include those key ones that I've listed there. So hypertensive disease during previous pregnancies, chronic kidney disease, autoimmune disorders, and any type of diabetes. Those are classified as high risk factors for preeclampsia, and those women should be given aspirin, low dose aspirin, from about 12 weeks until the birth of the baby. And that's been shown in many big studies to have a preventative effect on development of severe adverse outcomes. So really, really important. And we discussed this last time. What you effectively can do in preeclampsia, apart from aspirin, is to try and treat the hypertension, and then in severe cases, deliver the baby potentially prematurely. Okay, next topic. So diabetes in pregnancy affects about 1 in 20 pregnancies, so common, very common. And most of these women have gestational diabetes. Almost 90% have gestational diabetes. And just think about pregnant women. Most pregnant women are in their 30s or potentially younger. So these should be relatively fit and healthy people compared to the average person with diabetes. And so it makes sense that gestational diabetes is more common than, say, type 2 diabetes. And it's more common than type 1 diabetes simply because type 1 diabetes is quite rare. Diabetes in pregnancy, or poorly controlled diabetes in pregnancy, I should say, increases the risk of macrosomia in the baby. It increases the risk of shoulder dystocia, which we discussed last week. It also causes disorders of glucose metabolism in the baby, including neonatal hypoglycemia, and an increased risk of diabetes in the next generation, so in the baby when he or she is older. The neonatal hypoglycemia consideration is really important, and what essentially happens is that the baby becomes so used to a maternal high glucose load that flows through the placenta straight to the baby all throughout pregnancy, so that the baby's metabolism adapts to this constantly high blood sugar level. And then when the baby is delivered, he or she cannot maintain a normal blood sugar level anymore, because it has to kind of take over its own metabolism, and it produces too much insulin and becomes hypoglycemic, which can be dangerous in neonates. Everything is dangerous in neonates because they're quite vulnerable. And the last thing on this slide is that diabetes in pregnancy is really, really important to recognize, because good intervention and tight glycemic control can reduce the complication rates that we just discussed. Okay. So risk factors for gestational diabetes is almost certainly going to be a question in your exam. There are many lists, there are many resources where you can find these lists, but the key thing things to remember are a raised BMI, so overweight and obesity, previous macrosomia, so having a pregnancy with a macrosomic baby before, previous gestational diabetes, pretty self-explanatory, a family history of diabetes, and also ethnic origin. So all of these are quite self-explanatory, but just bear these in mind because it's really, really important, and it determines kind of risk factor stratification and whom to investigate for gestational diabetes in the clinic. Yeah. And the way we screen for gestational diabetes is through the oral glucose tolerance test. If a woman has any of the risk factors mentioned, she should be offered an oral glucose tolerance test around 24 to 28 weeks. And if you are at very high risk of gestational diabetes by having had a previous pregnancy where you've developed GDM, you should have an oral glucose tolerance test even earlier in pregnancy. One thing to mention though is that there are local variations to these guidelines. So at UCLH, where I used to work, we screened all women, regardless of risk factors, for gestational diabetes at 24 to 28 weeks. They had to drink an enormous amount of Lucozade, which some of you may think is a dream, but they didn't quite enjoy it so much. But just because diabetes was so prevalent, and it's difficult to know if someone has a risk factor that they don't tell you about, for example, or that they don't know about themselves. So we screened everyone. But in general, if there's a risk factor, screen at 24 to 28 weeks. And what happens is that you rock up fasted. You have a fasted blood test before you have anything to eat or drink. And then you wait around for 2 hours, try to not move or exercise or anything like that. And then you have a blood test after 2 hours. And the blood test is by venipuncture generally. I'm sure you can do it by capillary blood glucose as well. It's just a question that came up here, but at least at UCLH, it's a venipuncture blood test that you send off to the lab and you get the results afterwards. Another question here, is it common for these women to present with symptoms of diabetes? Yes and no. So what can be quite tricky is to determine what is a symptom of diabetes versus something that is normal in a pregnancy. So women can say that they feel more tired, maybe they feel more thirsty, and these kind of symptoms are quite non-specific. Far from everyone will have any symptom at all of classic diabetes, and that's partly why it's important to screen. So some women can report feeling more thirsty, peeing more often, feeling more lethargic, those kind of classic diabetes type symptoms, but many won't. Yeah. So that's partly why it's important to screen. That was just one of the questions that came up. Another good question, sorry, might be silly. When is booking usually? 6 to 8 weeks? Well, the booking is, yeah, usually I'd say average 6 to 9 weeks, something like that. Probably a little bit later. So what tends to happen is that woman rocks up to her GP as soon as she has done a positive pregnancy test, and the GP tends to refer to a midwifery clinic, or potentially if there are risk factors or if the woman has any health problems or so, you might be referred straight away to a high risk pregnancy unit. But so I say most of the women we saw at booking at UCH would be, yeah, between 6 and 10 weeks of pregnancy, something like that. Another question, why is it that they are only screened at 24 to 28 weeks if tight glycemic control is important to reduce complications? Well, so gestational diabetes tends to not develop towards until the second half of pregnancy. So screening everyone early, I mean, this is, I think it's partly because you're likely to have a lot of women who will have a negative OGTT in early pregnancy, but then go on to develop gestational diabetes anyway, and doing 2 OGTTs during pregnancy, I think it's partly because doing 2 might be too much for the system and too much for the woman and not necessarily yield more benefits. But the key thing to realize is that diabetes tends to develop towards at least the second half of pregnancy, when the metabolism changes in a way that makes you more insulin resistant. It changes kind of your lipolysis and glucose metabolism, and it is towards that later stage of pregnancy that you would develop gestational diabetes. So it makes more sense to screen at that time. Yeah. So the reason you're screened from 24 to 28 weeks is that that's when you're most likely to pick up gestational diabetes, and that's still early enough to be able to treat it effectively before term. Remember that babies don't tend to, or they don't grow in terms of size that significantly in the first half of pregnancy. It's a lot of organ development and really key processes that happen. But in terms of weight gain and really growth of baby and insulin dependent growth, that is really towards the third trimester mainly. And that's when you can have all these problems with poor glucose control. Okay, that's a really good question again. Okay, let's crack on. And here are the diagnostic criteria. There's nothing, there's no other way of doing this than to just learn them by heart. And this was one of the SBAs that I think many of you found tricky. You have to just learn these criteria, I'm afraid, for the exam. So gestational diabetes is diagnosed if either your fasting glucose is above 5.6 millimoles per liter, or your 2-hour glucose, so 2 hours after you've had your 75 milliliter glucose challenge, is above 7.8. Yeah, sorry, 75 grams oral glucose challenge. Okay. And this is likely to be a key question in your exams as well. How do you manage gestational diabetes? And I'd like you to think of it in a kind of stepwise approach, thinking both about lifestyle factors, so diet and exercise, and then medical therapies, starting with metformin and then insulin for those who need. So as soon as a woman is diagnosed with gestational diabetes by the criteria that we just had a look at, she should be booked into a joint diabetes and antenatal clinic within a week. So it is important to catch these women early. They'll be taught how to monitor capillary blood glucose themselves, just like any diabetic. They'll be given lifestyle advice on diet and exercise. And if the fasting plasma glucose is between 5.6 and 7, so if it's relatively low, you start off with a trial of diet and exercise. You monitor the capillary blood glucose for a couple of weeks, and if it's still not controlled, then you start metformin in the first instance. So very similar to type 2 diabetes, you start off with metformin. And then if glucose targets are still not met with metformin, then you start insulin after that. However, if on your oral glucose tolerance test, you already have a fasting glucose level above 7, or if you have a glucose level between 6 and 6.9 and evidence of complications such as macrosomia or anything like that, then you start with insulin straight away. Okay. And the management of type 2 diabetes in pregnancy is very similar in many aspects to that of gestational diabetes. So encourage weight loss and diet and exercise changes if indicated. You stop all your oral hypoglycemic agents. So if people are on sulfonylureas or anything like that, you stop those, but you can keep metformin going. Metformin is safe in pregnancy. But you also importantly start these women on aspirin, as we discussed before. Because diabetes in pregnancy is associated with an increased risk of fetal anomalies, you do a detailed scan at 20 weeks. Typically, you don't do a scan at 20 weeks for healthy pregnancies. You just have your booking scan. But for diabetic women, you should have an anomaly scan at 20 weeks as well. And you monitor for things like retinopathy, which can worsen during pregnancy. Question here, good question. Can type 1 diabetics develop gestational diabetes on top of their pre-existing diabetes? Good question. I don't know. I haven't heard about it. It's a very different kind of risk factor situation here. So risk factors for gestational hypertension is really kind of a lifestyle, family history of type 2 diabetes, obesity, those kind of things, whereas type 1 diabetics is much more of a genetic condition. I don't know is the honest answer. I'd have to look into that and get back to you, Julian, but I think that's a good question. Okay. Another question here. Is there any implication for the fetus if the mothers restrict their diet and have weight loss during pregnancy? So this is a good question, and there's a lot of research into this. What we try and encourage in women who are overweight is to try and not put on any weight during pregnancy. So most women, of course, do put on weight during pregnancy, but for women who are already overweight, we encourage them to at least maintain the weight that they had at booking and not put on any weight. It is very, very rare in this part of the world that women are so nutritionally restrictive for dieting reasons or so that their babies don't grow properly. The baby tends to take, so to kind of steal, so to say, their mother's nutrients and glucose and grow very well, even if the mother has a slightly worse diet than she should, or if she takes in too few calories or so on. So it's very rarely a problem. Obviously, having said that any extreme is dangerous. We know, for example, in women who've had bariatric surgery and have a very low calorie intake per day, that those babies are predisposed to fetal growth restriction, for example, because of poor nutritional intake. So in short, it can happen that if you restrict your diet too much, it's dangerous for the baby and you risk fetal growth restriction, but it's very rare, and keeping a stable weight during pregnancy for someone who's overweight at booking is preferable to putting on weight. Yeah. Another couple of good questions here. Yes, so this slide, type 2 diabetes in pregnancy, this slide that we have up right now is for those women who have type 2 diabetes before booking, so pre-existing type 2 diabetes. How regular are the checks once you've started intervention? It depends on other risk factors in the mothers as well. They can be as often as every few days or weekly, to just following the regular schedule. If you're on a if your capillary blood glucoses are normal, you're doing your diet and lifestyle well enough to kind of keep everything under control, and your OGTT tests were only in that kind of mid-range, that only just about made you have a diagnosis of gestational hypertension or diabetes, then you don't have to be monitored more often than any other woman. But it depends on individual factors. Okay, let's go through group B strep. It's very, very common to carry group B strep in the vaginal flora and also in the gut flora. Somewhere between 20 and 40% of women carry group B strep. And as you then can understand, it's most commonly an asymptomatic infection. It can give you symptoms of a UTI. But also during pregnancy, especially, group B strep colonization, which means basically that the group B strep takes over from the other parts of the vaginal flora, so that there's an imbalance of group B strep and other vaginal flora. That is a risk factor for septic abortion, so effectively miscarriage because of sepsis in the fetus. and postpartum endometriosis. And it can cause loads of problems in the newborn, especially neonatal sepsis, neonatal pneumonia, and meningitis. So really, really important to treat it if indicated. But it's of course tricky to figure out whether or not someone will be affected by group B strep because it's such a common asymptomatic infection to carry as well. All right. Risk factors for any of these adverse outcomes of group B strep include prematurity, prolonged rupture of membranes, and maternal pyrexia. So, and this relates to the question that we just had a look at. All high-risk mothers, so for example, if they've had GBS problems in a previous pregnancy, they are having premature labor or prolonged rupture of membranes, are given antibiotics during labor. And the antibiotic of choice in women who are not allergic to penicillin is IV Benpen, clindamycin otherwise. And then after babies are born to women who have grown GBS during pregnancy and there's any risk factor for GBS septicemia in the baby, they should be observed for at least 24 hours after delivery. So that's basically doing regular obs on the babies, being very, very vigilant to any signs of sepsis in the babies. And if there are signs of sepsis, so things like blood pressure going off, heart rate going off, anything like that, then you have a low threshold for giving Benpen and gentamicin to the baby and doing a full septic screen. Okay, the rest of the infections in pregnancy I'm going to run through quite quickly because I do want us to talk about the psychiatric conditions, to spend a bit of time doing those. But we'll have a couple of slides on the other infections in pregnancy. Do feel free to ask questions as always. Parvovirus B19 is a common condition that affects loads of children. You've probably heard about it in pediatrics, being called slap cheek syndrome. And I put up a picture there of what it can look like when a child or a toddler is infected by parvovirus B19. In most children, it's a self-limiting viral illness. So they get this rash on their cheeks. They can get a maculopapular rash all over their bodies. They can get a bit of a fever, feel lethargic, get those general kind of virus symptoms, and then the infection tends to go away on its own with no intervention. But it's dangerous in immunocompromised individuals. It's dangerous in individuals with hematological problems. You might have heard of sickle cell disease patients getting aplastic crises from parvovirus B19. And it can be dangerous in pregnant women, and that's why we're going to just briefly mention it here. So maternal parvovirus infection, especially if the mother has never been exposed to parvovirus before, can be dangerous because the virus can pass straight from the mother via the placenta to the fetus. And it effectively causes anemia in the fetus, such that the fetal circulation becomes hyperdynamic and the baby effectively can't cope with the anemia, and it develops heart failure, which results in fetal hydrops. And fetal hydrops is essentially fluid accumulation where there shouldn't be fluid accumulation. So pleural effusions, pericardial effusions, ascites, edema, and it can lead to neonatal death or fetal death. Yeah. If it's suspected, you should, as a midwife or a clinician, contact the local authorities. There needs to be some contact tracing, especially if the woman has had contact with other pregnant women. And if it's confirmed, then the baby needs to have proper monitoring in a fetal medicine unit with scans, checking if there's any sign of fetal hydrops in particular. And the baby will, or the fetus will be considered for either watchful waiting, IgG, or delivery early of the baby, depending on which stage of the gestation the baby is in. But it's potentially very dangerous. It's quite rare, but it's a potentially dangerous infection in pregnancy. Another viral illness that tends to be self-limiting in healthy individuals, but potentially dangerous for pregnant mothers, is cytomegalovirus. It's a very common infection, and if it passes from the mother to the baby, it's associated with complications to effectively any body system. So fetal complications include things like jaundice, hepatosplenomegaly, chorioretinitis, which I've put a picture of there, right, on the slide, hearing loss, cerebral palsy, and even death. I want you to think of CMV complications as mainly being neurological, yeah. And the treatment is intravenous ganciclovir. The very last one of the infections in pregnancy before we crack on is toxoplasmosis. And this is toxoplasmosis is the reason why we advise pregnant mothers to not eat anything like undercooked beef or handling cat litter. It's a parasite infection that can cause cataracts, deafness, and cognitive impairment in the newborn. If you suspect that a mother has toxoplasmosis, she should have spiromycin quickly, because that prevents the parasites from going from the mother via the placenta to the baby. And if you have a strong suspicion that there's already been infection, then pyrimethamine, if it's in the 2nd or 3rd trimester, is indicated. And I put up the map there to show you that it's considerably more common in France, maybe because of different food consumption, eating a lot of rare meat, etc., etc. But yeah. Okay. We just have a couple of slides on obstetric cholestasis before moving on to the psychiatric conditions. So what is it? Obstetric cholestasis, or intrahepatic cholestasis of pregnancy. Not a very common condition, affects about 1% of pregnancies. It is associated with an increased risk of prematurity and stillbirth. The cause of obstetric cholestasis is not entirely clear. Part of it has to do with hormones, so a high estrogen level causes this kind of sluggish flow of bile, but there's also a strong genetic component. So a family history of obstetric cholestasis is a major risk factor for developing it yourself. What happens in obstetric cholestasis is that there's an impaired flow of bile, and these bile salts deposit in the skin and placenta, and this causes both this itching where the bile salts deposit in the skin and placental damage, and inability of the fetal liver to break down the excessive bile salts that are transported from the mother to the baby. And that's why it can be associated with miscarriage and fetal death, because the fetus liver essentially gets overwhelmed. And the key thing you'll find both in clinics and in your SBAs is this intense itching. Palms, soles, and abdomen. Women can itch so much that they have like scratch marks that can look quite severe. And you'll find that in almost all women, they'll have raised bilirubin. It's not a super specific sign, because of course there are things like Gilbert syndrome that can cause a raised bilirubin without obstetric cholestasis. But raised bili, jaundice in about 1 in 5, and it's common for women to develop it in their 2nd pregnancy if they've had it in their 1st, etc., etc. And yes, the management is using ursodeoxycholic acid, which is derived from bear's gallbladders, and women are monitored with weekly LFTs. If they rise very substantially and the woman is symptomatic and it's getting towards the later stages of pregnancy, then it's common to deliver the baby, even if it's a bit early. Okay, last topic for today. I bet you're all hungry and tired. So last topic is one that I find really, really interesting, and that is so key to clinical practice. We're going to talk about psychiatric conditions related to pregnancy. All right, so going through these conditions that are psychiatric conditions related to delivery and pregnancy. Baby blues is a really, really common condition, affects most of women who've just given birth. And what women describes is most commonly tearfulness, feeling tearful, feeling a little hopeless, feeling like they're not coping. It tends to be limited to a few days after birth, and the symptoms go on for a few days, maybe a week. I think a key thing to know about baby blues is that it does not typically involve any thoughts of self-harm or feeling that they should cause harm to the baby or anything like that. It typically involves feelings of not quite coping, feeling tearful, feeling really tired and depressed. But it tends to be self-limiting, and for most women just reassuring. So whether it's a key worker who comes home and reassures the mother, or whether it's a GP, or whether they speak to their friends who know all about it, or etc. Reassurance is really the most important part of baby blues, because part of management of baby blues, because a woman who knows that it's going to pass in a few days and don't have any adverse thoughts such as self-harm or suicidal ideation, she will most likely just recover on her own in a few days. It's more common in primates. It's also more common in women who have a low level of support network, whether that's friends or partner or family members or something like that. Okay. Next one, which there was a question about, is postpartum depression. And these women typically present a few weeks after delivery, and they describe typical depressive symptoms. So most of you already know about the typical depressive symptoms. So anhedonia, not being able to sleep, feeling tired all the time, feeling tearful. It affects about 1 in 10 women, so it's relatively common, and it is important to screen for. And what is particularly important is to recognize the women who are going to need more help here. And those are women who describe any thoughts of harm, or any thoughts of self-harm or suicidal ideation, or really saying that they're not coping because they should be supported in order to prevent this from progressing any further. And the key thing to do in a primary care setting is to screen women using the Edinburgh Postnatal Depression Scale, which is a very straightforward questionnaire that gives you a kind of risk of a woman having postnatal depression. Okay, this is the last couple of slides. The management of postpartum depression is a kind of stepwise approach. So if there's a woman who doesn't have any adverse feature, any adverse or risk features such as suicidal ideation, self-harm, those kind of things, then reassurance and support are really important. Maybe if you're a GP, booking in a couple of extra visits to just monitor and make sure that there's nothing else that the woman needs to support with can be important. Cognitive behavioral therapy, also very effective, and also acts as a safety net for picking up women who may progress towards more severe depression. If needed, then SSRIs such as sertraline and paroxetine are considered safe during breastfeeding and effective in postpartum depression. Last one, puerperal psychosis. I just want to mention one patient that I saw with puerperal psychosis in a psychiatric unit, and she had continuous thoughts of someone telling her to harm her baby and kill her baby, and in the end she did kill her baby by placing the baby in a pot of boiling water. And obviously this is about as severe as it gets, but I think the reason I mention this is to make it clear how important it is to recognize this condition early on, to recognize that these women need a lot of support, they might need to, or most likely will need to, be admitted to hospital. And they will need a lot of support, both kind of psychological input and medication, most likely. Okay, it is an uncommon condition, 0.2% of women affected, but when it does happen, it is key to pick up the signs early and to put in a lot of support. Okay, so acute onset of manic or psychotic episode symptoms shortly after childbirth. Onset is usually within the first 2 to 3 weeks following birth, partly due to genetic and partly due to hormonal changes. Okay. All right, so that's all from me for today. Thank you so much for bearing with me. Sorry, it's just a few minutes late. I hope you found it interesting, and hopefully I'll see you around on the ward someday as well.